Hi, welcome to Mastering Anesthesia. If you've clicked on this video, you're probably here to learn about Propofol. Did you know the basic structure of Propofol, which is a phenol, is actually neurotoxic, yet we are using it rampantly in our OTs for its effects on the brain, making it one of the most popular and preferable IV induction agent worldwide. So how is this so? Let's look into the structure and what makes it safe to use. What are its uses, pharmacokinetics, pharmacodynamics, and as a bonus, Propofol-Related Infusion Syndrome. So watch it till the end and let's go. Now let's get to know Propofol. Its chemical name is 2,6-diisopropylphenol. Start with a benzene ring, a 6-sided hexagon with a circle in the middle. Attached to it is a hydroxyl group. This is a phenol. And draw 3 lines on either side right next to the hydroxyl group and attach CH3 on each ends. You get yourself a propofol. The carbon attached to the hydroxyl group will be carbon 1 and followed consecutively 2, 3, 4, 5, 6. So attached to carbon 2 and carbon 6 are these bulky molecules called isopropyl groups. They help in the lipophilicity of propofol. Propofol is also known as a hindered phenol. This is due to the 2 isopropyl side chains which are bulky and protects the hydroxyl group on the benzene ring. This is a phenol, and phenol is neurotoxic. It can cause burn, CNS depression, as well as seizure. So what's the formulation of propofol? So it is either 1 or 2% solution of propofol in aqueous solution with 10% soybean oil, 2.25% glycerol, and 1.2% purified 8-phosphatide. The soybean oil holds the propofol in a medium that can be dispersed and stabilized. The glycerol maintains the isotonicity of propofol in blood, and the 8-phosphatide provides lecithin, which acts as an emulsifier to stabilize the small propofol soybean oil droplets in aqueous solution. When we're talking about central receptors in the brain, there are inhibitory neurotransmitters as well as excitatory neurotransmitters. The major inhibitory neurotransmitters are the GABA-A and glycine, and the major excitatory neurotransmitters are the NMDA and neuronal nicotinic acetylcholine. Propofol enhances the effect of GABA-A neurotransmitter. Now let's talk about GABA-A receptor complex. It is a pentameric ligand-gated ion channels. It has 5 subunits, and ligand-gated meaning something has to bind to it for it to be activated and allowing ions to pass through. The 5 subunits are gamma, alpha, beta, and beta. The triangles show the agonist site for gamma aminobutyric acid, and the gamma alpha interface is a modulatory site for benzodiazepines, whether it is agonist or antagonist. Agonists are midazolam, diazepam, tenazepam, and antagonists are flumazenil. The beta subunit is the general anaesthetic site, and this is the site of propofol action, etomidate, as well as barbiturates and halogenated volatile anesthetics. So these act as agonists for the GABA-A receptor complex, and once it is activated, the chloride ionophore is activated and chloride is able to pass through the channel. Now let's put things into perspective. This is a propofol attaching itself to the GABA receptor complex. Chloride diffuses in, causing hyperpolarization. So action potential cannot be transmitted from the pre to postsynaptic terminals. So propofol helps in increasing the opening time of the chloride ion channels. It also slows down the GABA dissociation from its GABA receptor complex. And finally, it prolongs the inhibition of neurons. So by blocking the transmission of action potential, it causes its sedation, CNS depression effects, and also amnesia. Important distinction that needs to be pointed out is that propofol does not cause suppression of the spinal motor neurons, unlike volatile anesthetic agents. So at a glance, Propofol significantly enhances the effect of GABA-A at GABA receptor complex. Some minor enhancements seen at glycine receptors, no effect at NMDA receptors, and there is antagonistic effect at neuronal nicotinic acetylcholine receptors. Propofol has many clinical uses, hypnotic and non-hypnotic. Primary function is for induction of anesthesia at a dose of 1.5 to 2.5 mg per kilogram IV at blood levels of 2 to 6 microgram per ml. Propofol can also be used for intravenous sedation. Conscious sedation can be achieved by infusing 25 to 100 microgram per kilo per minute. It can be used for maintenance of anesthesia. So this can be achieved by infusing 100 to 300 microgram per kilo per minute. There are also non-hypnotic uses of propofol. It can be used as an antiemetic with a dose of 10 to 15 mg IV, which is subhypnotic. Propofol can also be used as an antipyretic with dose of about 10 mg IV. Propofol can also be used as anticonvulsant, and lastly, attenuation of bronchoconstriction. Propofol in its solution has a pH of 6 to 8.5 and a pKa of 11. Being a weakly acid solution at a physiological pH of 7.4, it means that almost all are unionized. Also, propofol has a molecular weight of 178. Talking about pharmacokinetics, you are talking about the ADME of the drug. So absorption, it is only licensed to be used as an IV preparation. Therefore, its bioavailability is 100%. For its distribution, remember that propofol is very protein bound at 98%. Its volume of distribution is very large at 4 liters per kilogram, and its distribution half-life is 1 to 2 minutes. This explains for patients' rapid recovery after bolus injection. Propofol's unique metabolism contributes to its widespread use in sedation, TIVA, and prolonged infusion. It is metabolized in the liver by the cytochrome P450 enzyme. It's inactivated to glucuronide sulfate or glucuronide conjugates of hydroxylated metabolite. Important note that propofol does not have any active metabolite. There are also extrahepatic sites for its metabolism, mainly the lungs, and some minor contribution from the kidneys and intestine. Metabolism of propofol is hugely unaffected in hepatic and renal diseases, safe to use in patients with liver conditions and kidney disease. Excretion. Propofol's metabolites are largely excreted through the urine, with less than 0.3% are excreted unchanged. Clearance of propofol is 30 to 60 ml per kilogram per minute, and its terminal elimination time, half-life, is 5 to 12 hours. Remember that terminal elimination does not reflect the duration of action of propofol, but it just reflects how long the propofol lingers in your system. And clearance of propofol is reduced in renal failure, but owing to propofol's metabolites does not have any active activity, there won't be any prolonged effect of propofol even in renal failure. Propofol is great for TIVA, which is total intravenous anesthesia, because of its short acting and short half-life. So patient will have rapid recovery and it avoids accumulation even after prolonged infusion. It provides smooth and fast induction. It has high clearance and rapid elimination, predictable and linear pharmacokinetics, and propofol can be safely administered with other drugs such as remifentanil, alfentanil, and fentanyl. And lastly, propofol has short contact-sensitive half-time, which is the time it takes for the blood concentration to fall by 50% after stopping an infusion. And context in this sense refers to the duration of infusion. So in prolonged infusion of propofol will start to accumulate in fats and muscles. They become saturated, and later on, the propofol concentration will redistribute back to the central compartment. But due to its rapid metabolism, its effect won't be seen for long. So context-sensitive half-time for propofol infusion for about 2 hours will be around 20 minutes. 6 hours of infusion, about 30 minutes, and 9 hours in infusion, the context-sensitive half-time is only about 50 minutes. Propofol TIVA is popular in its use in neuroanesthesia due to its no increase in cerebral blood flow, no increase in ICP, and it maintains cerebral autoregulation. Now let's see what propofol does to every other organ system. In cardiovascular system, it reduces the systemic vascular resistance, reducing in blood pressure. Reflex tachycardia is rarely seen, however bradycardia is more common. It reduces sympathetic activity and reduces myocardial contractility. As for the respiratory system, propofol causes respiratory depression as well as apnea. It reduces the response to hypercapnia as well as reduces laryngeal reflexes, making LMA insertion easier. Propofol's effects on the central nervous system includes reduction in cerebral blood flow, cerebral perfusion pressure, as well as cerebral metabolic rate of oxygen consumption. It is also as anticonvulsant. However, excitatory effects have been seen, such as dystonic, coriform, opistotinus, but these do not represent true cortical seizure activity. Gastrointestinal tract. Propofol has an antiemetic effect. This can be due to the antagonist of dopamine D2 receptor. Propofol has no effect on the kidneys and the liver. It causes pain on injection. Metabolic. Propofol causes hyperlipidemia. Fatty infiltration of different organs are also seen. And some miscellaneous effects seen with the usage of propofol includes hair and urine turning green. Now come the exciting bit. We've been talking about propofol in positive light. However, there is a fatal complication associated with propofol. It is called Propofol Infusion Syndrome. It is a rare, life-threatening condition due to prolonged infusion of propofol, commonly seen in ICU sedation. Key features seen in Propofol-Related Infusion Syndrome include refractory bradycardia that may lead to asystole, and one of the following features, such as metabolic acidosis with base excess of more than negative 10 millimole, rhabdomyolysis or myoglobinuria, lipemic plasma or milky presentation of plasma, and or enlarged fatty liver. Typically, its presentation occurs after an infusion has been going on for more than 48 to 72 hours. Risk increase after the doses of more than 4 mg per kilogram per hour, and is seen in children as well as adults. How does this come about? This is due to the interference of the mitochondrial energy production, especially in the oxidative phosphorylation and electron transport chain. Therefore, cellular energy failure ensues. The cells cannot utilize its energy, therefore it will die and necrosis ensues. Now, what are the signs of propofol-related infusion syndrome? New onset of metabolic acidosis, ECG changes particularly but not limited to Brugada syndrome, cardiac dysfunction, as well as increased creatine kinase levels of more than 10,000 units per liter. So what are the precautions that we have to take, and what are the parameters that we have to monitor? Do not exceed the use of propofol at 4 mg per kilogram per hour for more than 48 hours, and monitor for CK, lactate, triglyceride, ECG, and ABG for acidosis. And there you have it, guys. Thank you so much for watching this very special video I've put meticulous attention to. I hope you find it useful. If it does, care to hit the subscribe button. It will definitely help my channel grow to help more people. Drop a like and comment on topics you want covered next. I'll see you in my next video.